Welcome. Five Wishes is pleased to present today's practice community webinar, Measuring Advanced Care Planning Outcomes. I'm Dave Simonson, the Vice President of Operations here at Five Wishes. It is now my pleasure to introduce Kathleen Taylor, our Five Wishes Healthcare Programs Director, who will facilitate our webinar today.
Thanks, Dave. And thank you for joining us for our webinar today, Measuring Advanced Care Planning Outcomes. We host these informative webinars about quarterly, and we focus on topics that you tell us are the most relevant through your feedback. And for anyone new, the Five Wishes practice community is for any healthcare professionals that use any components of the Five Wishes program. Our primary goal with the practice community is to empower all of you who do the work of advanced care planning to foster truly meaningful, effective, and compassionate advanced care planning conversations. And we do this by highlighting best practices and innovations and thought leadership. The practice community serves a purpose in our national nonprofit Aging with Dignity's mission to educate and advocate. By providing sessions like these, we continue to pull in experts and offer guidance to assist all of us in providing the best care for the most vulnerable that we serve. For the practice community, we also provide mentoring and guidance for questions that you might have about advanced care planning. If you think mentoring would help you, please email your questions and concerns to us at practicecommunity@fivewishes.org. We hope you find today's webinar useful. At Five Wishes, we work with thousands of healthcare organizations, and we frequently hear about the challenges and frustrations in measuring advanced care planning outcomes and even defining what to measure. There have been plenty of published research articles conducted to measure advanced care planning outcomes. And there's also been plenty of journal articles that either support or question that research. So it's a topic of a lot of debate currently. At the end of the day, I think we all want to establish that the work we're doing in advanced care planning is enhancing the quality of care that we provide, and we want to be able to support the case for continuing to do it. And measurement, to me, is one of the most important things that we can do, and I'll talk about a few reasons why. First of all, measurement is a way of ensuring that the activities that we're conducting, the advanced care planning actions, interventions that we're doing those well, that we have skilled facilitators, that our processes are working, that we're having conversations across the lifespan, that we're discussing what's most important, really engaging in shared decision-making as people experience changes in their health, and eliciting the right information in advanced care planning conversations. So we want to make sure that we're doing the thing that is advanced care planning in the most effective ways. Another reason it's important is measurement ensures that advanced care planning is a contributing factor to high quality and value of care. If it's not, we shouldn't do it. But it probably is, especially if you're doing it well. Another reason is measurement ensures that leaders and managers can meaningfully and be empowered to meaningfully advocate for the time, resources, training, and support required to do advanced care planning well in all care settings. And another reason, lastly, is that measurement ensures that the people we serve have beneficial experiences and good outcomes from engaging in advanced care planning. So it's a big deal, and it's also really challenging to do. And we are so lucky to have with us to talk about this today, probably the preeminent expert in measurement. We have Tori Fields with us today. Tori's a skilled strategist, economist, and population health researcher, and a passionate advanced care planning advocate. She has over 15 years of experience working with payers, employers, purchasers, and providers to design and implement high-value and data-driven healthcare programs that improve the lives of people with serious illness and the lives of their families. She serves as a strategic advisor and faculty with several different organizations and has been directly involved in the design of many of the value-based care and payment models that you might be familiar with. We feel extremely lucky to count Tori as a friend to Five Wishes, and we thank you for being here. Welcome, Tori.
Oh, thank you so much for having me. I must admit that this is my favorite topic. So I will premise this conversation by saying that these slides are a little bit text heavy, and we're going to make this fun. And these are going to be takeaway slides for you, so that you can get a little bit of a sense or an understanding of the framework by which we can really think about measuring advanced care planning. So don't be afraid by the words on the slides. They're really just takeaways for you. But to start, as Kathleen was saying, I have had the supreme opportunity to use my public health and population health expertise and apply it to value-based payment and to measurement and incentive programs for health insurance companies, for state agencies, and for the federal government, in really trying to think about and address where do services like advanced care planning fit. We know that we need them. We know that they are public health initiatives, but how do we make things like that more sustainable over time? So a lot of my work has really centered at the intersection of payment and measurement, which is why this is my favorite topic. I also have the opportunity to hold a number of roles with the Coalition to Transform Advanced Care, the Center to Advance Palliative Care, and the Center for Healthcare Strategies on their Better Care Playbook. And what our team is working on right now is working to build out palliative care benefits at the state level in a partnership with the National Academy for State Health Policy. So there are a lot of activities going on as it relates to people with serious illness. And I'm really passionate about how can we think about this more broadly and make sure that advanced care planning is really everywhere for everyone. I am a two-time cancer survivor, and I did not know what advanced care planning was when I was diagnosed at 19 years old. And I was led through my care without really knowing what was available to me. And so now I find it to be my moral obligation to pay it forward and help others understand what's available to them and how to speak up and think about their care, be more active participants. So I'm hoping to give you a little bit of a framework in terms of answering some of these questions that we often hear about when it comes to advanced care planning. Why should we focus on measurement? Kathleen shared some already. And oftentimes people ask me specifically as the finance person, what is the return on investment or the anticipated impact for advanced care planning? How should we think about it as it relates to payment? I'm going to just give a little overview and background on some of the challenges when it comes to collecting data as it relates to advanced care planning. And that is related to are challenges with reimbursement. And I'm hoping to then be able to give some of my thoughts in terms of where the field is going and where we can start to think about advanced care planning in a more population health framework. So to start, the thing that gets me really excited about advanced care planning is that it is for everyone. It can be approached as a population level or even a wellness activity. And there are a lot of opportunities to really apply advanced care planning to larger population frameworks, such as age-friendly health systems that a lot of health systems are really looking to undertake, and state master plans on aging that are trying to support communities that are aging in place. Advanced care planning is a really interesting reimbursement code already, because CMS has taken the stance that advanced care planning is a preventive service, which means that it is being performed in advance of a crisis. Now, they aligned that for people over 65 with the annual wellness visit, expecting or anticipating that a primary care provider would have an annual conversation with their patient and update their advanced care plan. What an ideal world CMS thinks that we live in. However, what we have today is an understanding that advanced care planning does need to be done when somebody has a serious illness. However, what I have seen the tension being, especially coming from a payer, is that how do we think about giving everybody the opportunity for advanced care planning in advance of the crisis? The challenge, though, is that a lot of publications have come out related to the impact of advanced care planning. And those publications have largely been in the context of cost. And we don't necessarily know what's on somebody's advanced care plan in order to determine whether their costs should be higher or lower. And that gives us an opportunity to really think about this from a consumer empowerment perspective, and to think about where advanced care planning fits as a requirement for care. So as I said, these slides are a little bit text heavy because this becomes complicated over time. One thing that we have learned, or I have learned in developing policies and payment models for people with serious illness, is that we need to offer or have a continuum of care delivered to people with serious illness. And that always starts with the initial kernel of advanced care planning. We need to understand somebody's healthcare wishes in order to determine what they need and how to refer them to additional services. So that's really the crux of all of these other models, including palliative care services, concurrent care, and hospice services. Advanced care planning is an underpinning of those things.
And Tori, I was actually going to highlight that as well, because it occurs to me that advanced care planning, you could go horizontally across this very top dark blue row, and advanced care planning is appropriate in all of these care services across, as I said in the beginning, across the lifespan and across the care continuum. So yeah, we could have that going through each of these models.
Exactly. In the definition of the model or the service, advanced care planning is repeated in every single one of these models, which means that you need to start with advanced care planning and do it repeatedly over time to better determine how people get access to which service and when.
And one more thing that I'll add about that is and you and I've talked about this. We hear from, as I mentioned, so many different healthcare systems, hospitals, and care providers. And one of the consistent things that we hear is that there is difficulty in finding what people feel is the appropriate ownership of advanced care planning. It is owned by different departments, palliative care, sometimes the cardiac. I've had cardiac floors owning advanced care planning. We've had chaplaincy services that kind of own advanced care planning, social work, discharge, admissions. So what we find is that there's very little consistency with where it fits in different healthcare organizations. And that is something that I think cuts both ways. It's difficult to advocate for how many resources you need to do this well if you don't have the leadership buy-in from a strong department that owns it. But the benefit of it not really belonging anywhere is that it can belong everywhere. Just like you're talking about with this slide, it can belong all the way across the care continuum, kind of like primary palliative care when we talk about the point of that. And I would love to see that it does, but one of the only ways we're going to be successful with that is if we help organizations figure out how to tie this in to some kind of organizational strategic imperative. If it doesn't get tied in, you probably will not have an easy time getting the resources and the measures of using those resources.
It's fascinating that you say this because I worked in the health insurance space for about 15 years. And in looking at it from that perspective, we had the exact same challenge, saying, where do these services fit when they are cross-cutting? And I was an actuary at the time. So it partially fit into finance and it partially fit into quality, which created and required a very strong partnership between clinical leadership in our organization and financial leadership in our organization. And that alignment really is something that must be driven from the top. So for the leaders on this webinar, there is a responsibility to say, okay, how do we set this up in a way where it is sustainable and where it can really scale? To this point, there has also been some real opportunity in starting to think about and discern between what advanced care planning is and what serious illness communication is, or goals of care conversations that are completed over time. One of the challenges with reimbursement for advanced care planning, as I shared, is that it was set up to be a preventive service. So that is different from serious illness communication and anticipates that these are decisions for future care when you are someone who is well. And it is something where you can have conversations with a colleague or a friend or a clergy member that doesn't necessarily need to include a clinician as part of advanced care planning. When we start to think about medical decision making, that's when we move into serious illness communication, where there does need to be some partnership between a person, their family, the community, and the healthcare delivery system. And that's something that wasn't always necessarily accounted for in the reimbursement structure for advanced care planning today, and is why you're hearing a lot of the impetus or the push to advocate for some of these bigger care models, because advanced care planning is really the kernel that lives within all of those different care models for people with serious illness. Back to what Kathleen was saying in the introduction, there have been a number of publications related to return on investment of advanced care planning. However, those return on investment or impact evaluations have assumed that somebody's advance directive would actually reduce the care that they receive. And we're not certain what is on somebody's advance directive. So I'm not certain that I can put my money behind saving money for advanced care planning. However, what we do know is that it allows for a conversation to begin and for decisions to be considered and for decisions to be documented for future caregivers. So it may not be that advanced care planning doesn't work, but maybe we're measuring the wrong things. So you look at something like clear, simple, and wrong, or what's wrong with advanced care planning. And some of those things are really that we are measuring the impact of utilization of services rather than somebody's empowerment around decision making. As I said, again, busy slides here, but some general overview on reimbursement for advanced care planning that makes this a little bit difficult to evaluate. As I shared previously, oh, go for it, Kathleen.
I'm sorry, I didn't mean to interrupt you there. We've had a really good question come through, though, that fits in with what you've got right here in this portion. There's this, it's wonderful that Medicare has this as an avenue, and then as you're talking about some of the caveats with that, but I'm curious if you've heard about there being reimbursement for advanced care planning, again, across the lifespan, everyone over 18. I know that private insurers do frequently pay for that. But we're not seeing that as, Medicare tends to drive and shape the models because it's such a big payer and because it's usually the bulk of how most healthcare systems are getting reimbursed. It tends to drive the way they do care. So is that something that you see on the horizon, having advanced care planning conversations reimbursed by more and more payers for people across the lifespan?
Absolutely. CMS already reimburses for advanced care planning using these two codes. So those codes are available for any insurance company to reimburse for. And so that's the first thing. What we have heard over the past couple of years, as you were sharing, is that some insurance companies on the commercial market have either decided not to turn on or pay for those codes, or have different rules in place that make it difficult to be reimbursed for services. This is an administrative problem. So this is something that is a state by state problem that needs to be fixed on the commercial insurance market, where commercial insurance companies should be paying for advanced care planning today under CMS rules. So this is something to advocate for at the state level if your health plan does not reimburse for advanced care planning. Now, there are a number of challenges with the advanced care planning codes that have some changes that we're seeing, being explored. One of the things that is specific to the advanced care planning codes is when a copay applies. So for advanced care planning to be considered a preventive service, it must be coupled with an annual wellness visit, and it must be performed on the same day by somebody's primary care physician performing the advanced care planning visit and the annual wellness visit. And it's in those circumstances where the copay becomes zero. Now, my research partner, Susan Anguidinos, found that in review of those advanced care planning codes, 50% of the population accesses advanced care planning through the annual wellness visit, but 50% access advanced care planning when faced with a serious illness. And they're seeking that support from a specialist, which means that the copay then applies. And so this becomes a challenge for the under 65 population, Kathleen, to your question, because if more people who are under 65 are seeking advanced care planning from a specialist, then they would be charged upwards of a 20% copay for that. And this is something that we are actively advocating to change because CMS has already ruled that advanced care planning is a preventive service. It just doesn't seem to be configured that way.
Which doesn't mean you can't do it with these folks. We're talking about reimbursement right now, but I want to make sure that when we talk about measurement, we also talk about just the measurement doesn't always have to be tied to reimbursement. These are the
Absolutely.
ones that are, but you can still do and should do advanced care planning with patients where there isn't a formal reimbursement structure like this.
Right. And this is something that, in terms of what must be measured, there are some things that are even more unclear here, where even if you are seeking reimbursement for advanced care planning, the coverage determinations are made locally. And so reviewers have different understandings of what counts for advanced care planning documentation. They have some parameters around that, around what they have stated needs to be documented, but it just gets more and more murky as you keep looking. When looking at this, CMS in their Medicare Learning Network newsletter identified these specific documents as what counts as advanced care planning documents. And this will be important a little bit later in the conversation because CMS has also been shifting some of this and these requirements to insurance companies that are starting to open up some of these expectations on providers. The major billing and payment issues are that, number one, advanced care planning reimbursement is not enough if it's completed as a standalone activity. It's not a serious illness conversation. It is something that was designed to be coupled with another visit. So it's not something that should be considered standalone from the payment perspective. It's also it's delivered when it's delivered by a specialist. It's considered a specialty, and so a lot of health systems, some health systems, maybe not a lot, have actually stopped allowing for reimbursement because of the disproportionate copay that gets applied when someone seeks advanced care planning. Also, social workers and nurses are often the ones performing advanced care planning as part of their scope, but they are unable to bill independently for advanced care planning services.
And
So
that's
that
always
means,
been something that's really, I think, irksome uh, to anyone who's been doing this for a while and who's highly skilled, because the reimbursement requirements are disconnected from the concept of us having the most skilled professionals conducting the conversations. The list of who are the what do they call it? The authorized professionals? What is the terminology? I think that's it. There's a list of clinicians that are allowed to do this, but it's not a list of who's the most skilled in advanced care planning. And if someone outside of those disciplines is extensively trained and very good at this, it doesn't matter, according to the reimbursement rules. And I will just say, I'm going to keep putting a flag in this. It doesn't mean that these people shouldn't be doing advanced care planning. It just has to do with the reimbursement. And there are some other creative, some other ways to think about the value of having your most highly skilled facilitators doing advanced care planning. Even if they can't bill for it, there's still reasons to do it that way, which I know we're going to get to later.
yeah, that's right. These are really, when you're looking at advanced care planning and why the results are inconclusive, when you're looking at the overall publications that we have today around the cost and utilization for advanced care planning, it's very difficult to even measure who has received it and where they're receiving it. And there are so many other things that really give context, that tell us that we need to measure something different, not that the services should be performed differently. And you look at this, and chaplains are not even able to bill at all. And so when you look at this, it's not that they are not doing it; it's that they are unable to account for the work that they do, and may even have more time.
And because electronic medical records are in many ways billing machines, these things get tied to codes. When people are pulling data about advanced care planning, often they're looking for billing codes, which is leaving out a lot of advanced care planning conversations and activity that may have occurred in ways that could not be captured by those codes. So it's to me a huge consideration in measurement. What looking at billing codes tells you is how many times you use those billing codes. It doesn't give us much information about quality or the nature of those activities.
Exactly. So, where do we go from here now that we feel really beaten down by fee for service advanced care planning codes? Well, we have started documenting when we perform advanced care planning through those codes, but we've also started to educate insurance companies and CMS about where advanced care planning fits, as we talked about. So when you find that 50% of the population is accessing advanced care planning through primary care, and 50% of them are not, you need to change your strategy. And so CMS has actually started coming out with federal and state level requirements that are related to equity and related to quality measurement. And the first one that changed was last year, which is that this affects Medicare Advantage plans. And this is their quality measurement framework, their HEDIS framework. And HEDIS is a way for health insurance companies to demonstrate the quality of care that they provide for their population. And in return, those Medicare Advantage companies get more money from CMS if they are higher quality. How cool is that? I really like HEDIS. The one thing I really like about HEDIS is that they are squarely focused on advanced care planning. And the HEDIS measures that changed in 2022, I'll share a little bit more about them in a second, but they have expanded the documentation for advanced care planning and have also incentivized these health plans to start demonstrating how many people in their population are receiving advanced care planning. They're not required to document through those reimbursement codes. So just something to think about. They can be creative as to how they create that data set to determine who gets the advanced care planning services in their population. That, coupled with managed Medicaid in the states, Medicaid agencies are now being requiring their managed Medicaid plans to deliver things like advanced care planning or caregiving services or personal care services to their populations. And so for those insurance companies that have Medicaid and Medicare beneficiaries, advanced care planning is in both of their measurement frameworks. So they need to have a way to document and deliver advanced care planning to their populations. And again, that's not tied to the reimbursement codes. They just need a solution. The additional piece to this, which is really interesting, is what changes are being made to hospitals and health systems. And there are two programs that are related to hospitals and health systems, the Medicare Shared Savings Program and the Accountable Care Organization programs, both of which are different payment structures. And they have requirements for advanced care planning as part of their measurement portfolios from CMS. So while some of the publications may seem inconclusive about what the impact is, CMS has demonstrated that this is a standard quality measure across their population for anybody over 65.
And Tori, are these the ones, the Medicare Shared Savings and Accountable Care, ACOs, is this where we're seeing the ability to reimburse for advanced care planning conversations with inpatient populations?
Yes.
Yeah, okay. That came in as a question, so I wanted to clarify that.
Great. So a little bit about HEDIS. As I shared, advanced care planning was added as a new HEDIS measure for 2022, so just last year. And this is our opportunity to educate insurance companies, but also to educate our providers who are delivering advanced care planning about what the value really is currently to CMS from a quality perspective. So Providers can be reimbursed for having discussions regarding advanced care planning with Medicare Advantage beneficiaries. That's actually something, Kathleen, to your point, that's something that all Medicare Advantage plans have to do. So if you're talking to a commercial insurance company that has a Medicare Advantage plan, they must pay for advanced care planning. It's a quality measure. In addition, they've really defined who is a person who needs advanced care planning at baseline. They said people 66 to 80 who have advanced illness or frailty or who are receiving palliative care, and any adults over 81, they need to have advanced care planning every year. So this is the requirement on Medicare Advantage plans from CMS right now. In exchange, go for it.
Well, I'm just, my brain is just attaching this to the earlier question about advanced care planning across the lifespan. So if we have let's say an Aetna that has a Medicare Advantage plan, they must provide this as a service for people, not only under that plan, but anybody who's purchasing a commercial insurance plan or a private insurance plan from them, correct?
They are not required to measure advanced care planning for any of their commercial beneficiaries. However, they are required to reimburse for advanced care planning for their population. So,
Okay.
absolutely. And this is something where it gives you a little bit of a framework, and the incentive to the insurance companies are that if you select the advanced care planning measure for these populations, you don't have to report other measures, including colorectal screenings, breast cancer screenings, mammograms, things like that for this population, because they have been carved out of some of the other measures. So there is an incentive on the health plans to get better at identifying who really should have these advanced care planning conversations, so that they are not subjected to other screenings or other requirements that may not be the best use of their time. The other thing that the HEDIS measures did was gave us a little bit more sophistication in terms of how we document advanced care plans. So the Medicare Advantage organizations were also given these requirements, including additional codes. So as you see, these are CPT codes that are more specific to what happened in that conversation of advanced care planning and what was the result. So they're really looking to start to tie some of the goals of care to the advanced care planning conversations to ensure that documents can be found in the medical record, or that they understand if somebody has cognitive impairment or not. Really interesting. However, as Kathleen was saying, the challenge with advanced care planning is that we don't have something that measures overall societal impact. What I like to take an approach for is really this socio-ecological model of healthcare communication or of behavior change. And that is really premised on the fact that we need to look at and measure things in different ways depending on the impact of the service that we're providing. And advanced care planning is a really interesting conundrum in this way. What does advanced care planning do overall for our population? Advanced care planning fits in the equity portfolio. It addresses equity through access to information, resources, and services. And so one of the best ways that we can do to measure that is the result of advanced care planning being a referral to another service. So instead of thinking about advanced care planning as something that may change utilization or change costs, we can think about advanced care planning as something that provides access. So it provides access to more knowledge. It also provides access to more services. And that allows us to deliver a further continuum of care. From the community perspective, what advanced care planning does is address access and inclusion through shared decision making and shared accountability. And that can occur in the healthcare setting, but it doesn't need to. Advanced care planning is something that definitely can be performed as part of just your community offering, and actually should be over time. And from the interpersonal level, it fosters trust through connection and authenticity. And some of the ways that we can measure that are really around personal empowerment and self-sufficiency, and how people feel in terms of being heard and understood by both their healthcare delivery system and by their healthcare proxy. So this gets to this individual level of why we need to do advanced care planning early and over time, so that we can measure self-efficacy and self-image through exploration of values and values-based decisions, which is what advanced care planning really is. I'll just share very quickly that for me, advanced care planning really hits close to home. I lost every person on this slide during COVID. My family is not in healthcare. They do not know how to navigate the system. But we had a network of caregivers who understood one another's values. And while our values were very different, we all felt empowered, and each one of us got the things that we wanted in the end. Advanced care planning does that for families, and that's what it needs to measure. It prepares people like my parents to interact with and navigate the healthcare delivery system. It empowers people like me and my aunt to understand the best decisions for them on a very personal level. And it enables beneficiaries to develop shared plans over time. And what was even more important was that it allowed for us to be on the same page and to advocate for what we wanted and to ask for help and to navigate even when resources were limited during COVID. And advanced care planning can hold space for that. So it's more than just a document and can be used in a lot of different contexts, which also is something that needs to be the framework for measurement. And one of the best ways that I have seen has come from community evaluations of advanced care planning. So Lauren Van Scoy from the University of Pennsylvania, Hershey, evaluated an advanced care planning game called the Hello Game by an organization called Common Practice. And they evaluated advanced care planning performed in churches with African Americans around consumer empowerment and action toward care. And what they did was actually look at different domains of advanced care planning engagement, rating increases in knowledge, self-contemplation, self-efficacy, readiness, and action. So you see on the right, some of the actions that people took toward their care. And on the bottom, you'll see how people's knowledge or their self-efficacy really changed. And these are things that can be performed in the community, these types of evaluations, relatively easily with some sort of basic scales and surveys. So in terms of thinking about measuring the impact of advanced care planning, one thing to do is to really divorce advanced care planning from just serious illness and look at advanced care planning as a population measure and as the first step to a standard of care overall for people. So we should be expecting that everybody is getting advanced care planning and that number is going up, and that 100% of the population in that you see in the HEDIS measures are receiving advanced care planning. We do need to go beyond coding to make sure that advanced care planning is occurring and that it has impact. So I would encourage the practice community to think about how you start collecting the advanced care planning conversations that are performed that are not being reimbursed, because that's important in and of itself to collect. Measurement and evaluation approaches then can collect data for activities in the community, and we need to start publishing on those things. And there are already tools that can be used for some of this evaluation. And the publications from Lauren Van Scoy have some of those scales in them that can be used. There are also new measures for hospice and palliative medicine that can be extended to other communities or populations that evaluate somebody's feeling heard and understood, or their overall experience of care. And that is based on a community survey called the Collaborate tool that can be delivered across multiple settings and multiple languages. So I would encourage you to really look at advanced care planning as something that can support the overall patient experience and overall patient empowerment or self-empowerment.
And as Dave mentioned in the beginning, we'll connect with you, Tori, and when we send the follow-up email, we'll send a link to how to access that Collaborate survey that you mentioned and investigate further into that. Thank you.
Awesome. We are participating in partnering with US Aging and the Coalition to Transform Advanced Care on an initiative to start expanding advanced care planning as part of services with AAAs and other community-based organizations. And so there will be a couple of sessions in October at the CTAC Summit related to advanced care planning and how we can measure it a little bit differently in order to address health disparities. All right. With that, thank you very much.
Oh, thank you, Tori. And we have had, I'll say this is really interesting. We've had quite a few questions come up that have to do with billing. So it's interesting to me that, we're trying to talk about a larger theme of measurement. And what tends to bubble up for people, because there's been so much attention to it lately, are the intricacies of billing and the qualified professionals and who can really have the conversation if the physician introduces it and what's the difference in the codes. And we will try to address those individually in some follow-up emails, but I didn't want to get too far into billing intricacies during this webinar because we're talking about measurement. I do want to ask a question of my own to get your help with. When we work with healthcare providers, what we mostly hear that they are measuring, the typical provider is measuring, and these are the standard ones, they're measuring number of completed advanced directives in the EMR. I'm not saying these are good or bad, but I just want to talk about some considerations with these. They're measuring, some people are measuring the number of conversations that are conducted and noted or coded with an F code or something in the EMR. Billing, of course, for advanced care planning during the Medicare annual wellness visits, which we've talked plenty about. Some particularly nonprofit hospitals are measuring community engagement in advanced care planning. And when you just talked about the study with the game, that's a great community engagement initiative. And then I would say even the more advanced measures are people trying to connect utilization patterns and correlate them or connect them with the presence of an advanced directive. I just want to mention those and ask, what are your concerns or considerations for those, since that seems to be where people are putting their energy right now? And it's important, I think, to address the real practical considerations so that people can leave this webinar with an idea of how can I do this better and how can I measure what actually has to do with the quality of our care and the experience of the people that we're serving. So given that that's where people are mostly aiming, what should we be thinking about differently?
I think in thinking about these different measures that are being collected, what strikes me is that we need to define the denominator. So the number of completed advanced directives makes a lot of sense. But how are you measuring that? And what's the expectation over time? And I think that that's what was really exciting to me about some of these payer-based quality measurement requirements, because they're expecting that a subset of this population, 100% of those patients, are getting advanced care planning. And so I'm interested in knowing what's the percentage that you expect getting a completed advanced care planning document, so that I would understand the context of that number. So if you're talking about number of conversations being completed, and they're being performed in the community, what's the percentage of your population who is seriously ill or older or fits into that area where you're really wanting to ensure that people are getting advanced care planning conversations really quickly, and you're closing that gap quickly over time. Otherwise, counting the number of conversations doesn't really put it into context or help us understand if we have improved or changed.
Right. Or if those conversations resulted in people feeling truly prepared and empowered to make decisions in real time. And the other thing with counting number of advanced directives, and I understand that's a really easy data point to extract, and sometimes that's the big challenge for health systems is what data can they get their hands on? What's the burden of retrieving the data or doing a survey, and that needs to be considered. But my issue with completed advanced directives, I'm not saying don't measure it, but completed advanced directives, that's not our goal of advanced care.
Well, having them completed it doesn't document the process. And
Right.
that's really the slide that I was sharing that says, what did people do? Self-contemplation or contemplation of these things is an activity in and of itself. And that can take a lot of time. And so we don't know and should not force people into making decisions too quickly. Otherwise, they're really not making their own decisions. So in terms of thinking about it that way, measuring somebody's action rather than completion helps you understand if they're actually changing or if there's a behavior change, which is really what we're trying to measure with advanced care planning.
That makes sense. We're about at the end of our time. We could go on and on about this. There's so much rich information, and you've done an incredible service for everybody who's listening to this webinar, Tori. Thank you so much for everything you've done and all that you've shared with us. Again, we will, if there were resources mentioned, we will send links and information about that in a follow-up email to everybody who's registered for the webinar. If you had an individual detailed question about billing, which there were a few, I apologize that we didn't address that on the webinar, but we will just get back to you in an email with some more information about that. So thank you for being a participant and asking those questions, and we will get back to you. And that's about it. And with that, thank you again, Tori, and I'm going to pitch it back to Dave to close us.
Well, thanks again. As a reminder, this presentation was recorded and will be available to view within 7 business days. You'll find it along with all of our other recorded webinars by visiting the 5 Wishes webinar page at 5wishes.org/webinars. Please feel free to share the 5 Wishes webinar page with your teams and your colleagues. And on behalf of all of us at 5 Wishes, thank you to our speakers and to you, our participants and attendees. Have a wonderful afternoon. Please, you may now disconnect. Thank you.